Shamir interviewed 3 of the contributors now, Jahangir and Ansam, I've known for a very long time, and also Tariq. So I hand over to Shamir. Shamir, I'm mute. Yeah. Unmute.
Thanks also everybody for today's really interesting contributions as well. Thanks to our 3 interviewees who have come along. We thought it would be good to just hear the articulated experiences of COVID as they were happening during that time as well. From the London perspective, well, when we did our project, and they've obviously lent their voices to. And it's not only I know some of our respondents haven't only contributed to our project, the Volkswagen project, but to all some of your respected projects. So I would like to invite to speak, I hope they are here now, Jahangir Alam, if you could just kind of experiences of, the experience of COVID. We'd like also to hear Ansar Bhai, if you could share your experiences as well. And last, but obviously by no means least, Tariq Khan, if you're here, it would be good to hear his experiences as well. So I will hand over to Jahangir now, and then we'll hear from you. Thank you.
Thank you so much, Shamia, and nice to see you all. John, it's a shame that this is the first time we're meeting and it's virtual rather than in person. It's lovely to see so many familiar faces, people that I've had the pleasure of working with over the past 2.5 years. My name is Jahangir Alam. I'm a British Bangladeshi doctor from Tower Hamlets. I was born and bred in Stepney Green. My family are from Sylhet, Bangladesh, and I'm a 2nd generation migrant. So today I'm going to share a little bit about my personal experience as a British Bangladeshi doctor and later a policymaker. So back in April 2020, I was working in Leicester. As part of your junior doctor rotations, you move all across the UK with very, very little control over where you go and what you do. And earlier, probably around February, March time, there was talks around how we're going to deploy the workforce to deal with the pandemic. And a lot of us were redeployed to either critical care, which is intensive care medicine, emergency medicine, which is A&E, or respiratory medicine, to deal with some of the milder but hospitalized cases of COVID-19. I was redeployed to A&E in Leicester at the time. Just as the pandemic started, I received a phone call from a colleague of mine, a British Bangladeshi colleague of mine, who was working at NHS England, who said to me, Jahangir, have you looked at the statistics of the first few healthcare workers who passed away from COVID-19? And to be honest with you, at the time, I had no interest in those statistics. I just wanted to keep my head down and focus on surviving, focus on not catching COVID myself and getting through what seemed like it was going to be eternity. And, as those statistics grew and it became more and more apparent and more clear that COVID was affecting ethnic minorities more than other communities, more specifically South Asian communities, it became a bit of a worry for me. I received a second call from this colleague of mine who said, we need to do some work around this. We need to start making some noise, start meeting with decision makers to see how we can best tackle this issue and minimize the impact. And it's difficult, working at the beginning of the pandemic, working with very little resources, and a lot of uncertainty. At the time, we didn't have much knowledge around COVID. It's, how it affects the human body and what we could do to improve outcomes for patients. So there was a lot of clinical creativity at the time. And, at the same time, we were thinking about how best to protect people. There was a lack of PPE, not only general PPE, but PPE that was suited for people who may have beards, who may wear headscarves, who may wear turbans. And, it was difficult as a South Asian healthcare worker to navigate that space and try to stay safe and advocate for my own community. As the first wave of COVID started to come to an end, Public Health England at the time published a report highlighting the ethnic disparities. And the one statistic that I was interested in was that British Bangladeshis were most likely or at the highest risk of mortality from COVID-19. And that itself was very worrying for me, being British Bangladeshi and working on the front line and being at higher risk. And I thought to myself, what can I do to minimize the statistic? What am I doing in Leicestershire? And I had a burning desire to return to my community in East London, where COVID numbers were rife. I worked across Tower Hamlets in Newham, where there's a huge population of British Bangladeshis. And for me, 15 years ago, I went to medical school on one statistic that, people from East London died 7 years earlier than people from West London. And that inequality was what drove me to study medicine and to train to become a doctor. And so, I felt at that point, at the end of the first wave, it was time to return home and work to serve my community, to protect my own community. And I knew it wasn't just the, at the time people were saying, it's genetics. South Asian people are a lot more, they have diabetes, they have heart conditions, they're at higher risk of strokes. And that's the reason why they're at higher risk of dying from COVID-19. But, as Halima and other colleagues on this call touched on, it was more than that. It was more than just what the physiology of an individual was that contributed to their risk of dying or being severely affected by COVID-19. And, coming back to East London and being able to treat patients from the British Bangladeshi community who were affected by COVID, either having COVID themselves or losing relatives to COVID, was quite a challenge emotionally and mentally. And I remember, there were times where we didn't allow relatives to visit with patients. And a lot of Bangladeshi patients who looked like my parents, whose names sounded like my parents, who spoke like my parents, died in my hands. And I was the last person they were able to communicate with, given that I was probably one of the very few doctors in the hospital and in the department who spoke Bengali. And, I still have flashbacks from those moments. And you may have remembered that Barts Hospital built a pop-up intensive care unit called the Queen Elizabeth unit to tackle the second wave. And at the time, my mother was admitted to hospital with COVID-19, and she was only probably a few floors below where I was working. And the intensive care unit was like nothing I've ever seen before. 150 bed intensive care unit laid across an entire floor of the Royal London Hospital, and a lot of the patients coming from the Bangladeshi community. In the background, I could hear Quran recitations as patients, their relatives had requested Quran cubes where they played Quran recitations in the last moments of life. And the turnover of patients was so rapid. And I kept thinking to myself, any minute now, the next patient will be my mum coming up the elevator.
Sorry, Jahangir, you've got 2 minutes left.
And just having that experience of treating Bangladeshi people, treating my own community, and then going on to do work around vaccines where, we had a lot of backlash from politicians and the public during COVID around how the South Asian community tackled COVID-19 and how they experienced COVID-19. We had Chris Whitaker, the Conservative MP, say that BAME communities, and sorry to use that term, but that was the exact quote, BAME communities are not taking COVID-19 seriously. And the government imposed more strict rules in Oldham days before Eid in the summer of 2020. Yet in Christmas 2020, when COVID numbers were rife, we were able to celebrate Christmas with no issues. And then later we see headlines across the papers saying South Asian communities are rejecting the vaccine. And, those headlines, those words in the media really do alienate and marginalize our community. And to navigate and to experience the pandemic as an individual coming from a marginalized community, and then also reading those headlines and listening to MPs and politicians say those sort of things, really does make you think, how we're perceived and what actually we're doing to tackle these issues. And over the past 6 months, as things are going back to normal, I've noticed that we're talking a lot less about how ethnic disparities in healthcare are important. And I think spaces like this, coming together and having these discussions and being able to influence policy where we can, is really vital. And although restrictions are lifted, COVID is still around, those ethnic disparities still exist, and it's important that we continue to collaborate and have these conversations. I thought I had a lot longer, and I wanted to talk a lot more about my experience and where we should be going, but you'll have my details. If not, I'll post it in the group, and I would love to talk to you guys about how we can move forward with some of these policies and some of these ideas. Sorry, I know I've gone over a little bit, but
no, it's fine. Thank you so much, Jahangir, for sharing that. And I'm sure there will be space in the last 15 minutes to go over some of what you've said and discussed. So thank you very much for that. We're really grateful. If we could have Ansar Bhai now, Ansarullah, if you're there.
Yeah, I'm here.
Hi.
Hello.
You.
Okay, sorry. My apologies first. Oh dear, sorry. My apologies for not being, in attendance throughout the whole conference. So what I might say might have been repeated already. And I was also not part of the Volkswagen project. But I, with my colleague Julie Begum, we worked with Dr. Chris Tang from the King's College. And I guess in terms of our role, we were kind of the sort of interface between King's and the local Bengali community. And I guess they chose us or appointed us probably because, we were from the community. Both of us live in the community, and we kind of knew what was going on the ground. We also recruited participants for the project, both elderly, male and female, as well as mediators, the young members of the family, community workers, and Bengali professionals. And as Dr. Jahangir Alam has already said, that within the South Asian community, the Bengalis suffered the most for a number of reasons. I think it was dependent on the sort of makeup of the community in terms of its class, economic status, the fact that they lived in Bengali neighborhoods, living close to each other, Many of them were frontline workers. They worked for NHS. They were the delivery drivers, couriers during the pandemic. And of course, Halima Begum has mentioned the sort of historical treatment of the community by the institutions had this kind of long-term impact. But also, I think initially the seriousness of COVID wasn't communicated or wasn't understood by the community. Hence, many in the community, I think, perhaps did not take the rules seriously. And of course, there were also practical difficulties once the rules were introduced. For example, we were told that one had to be isolated. Now, when you live in a sort of Bengali household with extended family members in an overcrowded situation, it was impossible to isolate one person in a room. So there were those kind of difficulties our participants were telling us, during the interview. And of course, there was the issue of trust. I mean, here I must praise and thank Dr. Jahangir Alam's work on social media. He had created a WhatsApp group. And I should point out, WhatsApp groups were inundated with conspiracy theories. It was rife with, where COVID originated from and what was the purpose of it. And even with vaccination, there was so much conspiracy theories floating around. I think it kind of, to an extent, confused members within the Bengali community. And it all kind of contributed about the, not taking it too seriously or not really being aware of all the rules and regulations that one had to follow. I'm sure Chris must have told you, we did work with another Bengali doctor from Birmingham, and we made a number of short video films, health films, to make the community aware about the seriousness of COVID and what to do to prevent. We also made an animation based on a Bengali pharmacy worker highlighting those kind of difficulties during the sort of pandemic lockdown. I guess in terms of our sort of findings and conclusion or recommendations, I would say that this is obviously for the government and the institutions, and I guess if we were to face future crisis, our finding says that one has to work with people from the community, elders from the community that community look up to, that they trust. And secondly, we ought to work with Bengali professionals like Dr. Jahangir Alam and others, Bengali speaking nurses, and other NH staff that people can trust and depend upon for information. And finally, I think one that we were taken by surprise is the use of Bengali press and media. I mean, we are aware some literature were translated into Bengali and distributed by local GPs, counsellors, and NHS. But I think there are many within our community who aren't literate in Bengali, especially elderly women. And to reach out to them, not just the print, but we think the Bengali TVs, there are at least, I think 6 or 7 satellite TVs based in the UK, and they're watched by the entire population. And those TVs could have been used to reach out to the community. I think I'll stop here. I mean, Dr. Chris, who's here with us, might want to add, if you, and Tariq Khan's also here, I think, who was part of both projects. Thank you.
Ansar Bhai, you've got 3 minutes left before to just...
I'm done, it's okay, go to the next person.
Very much, Ansar Bhai. Okay, so next we have Tariq Khan, if you're ready.
Yeah, thank you, Shamia. I think it's a great project. Just want to say hello to a few people. Ansar Bhai, Jangir, Halimafa, Chris, long time, mate. Yeah, it's actually really good to be here. So when sort of COVID began, and so sort of it started going up, and the rates kept on going up and up. I was working in actually Vauxhall, and at the end of sort of March, the trains were getting like, quieter and quieter, and people were saying, don't get on the trains, don't get on the trains. And then like, I think it was mid-March, people were saying, just don't get on the trains at all. So you could see the sort of physical change in sort of in central London, what was happening. I think, and now I was an elected councillor at that time, and obviously there was a huge sort of panic amongst communities, a lot of elderly people who didn't understand what was happening, but also were scared. Elderly people who were scared, who didn't want to go to doctors. I remember one person telling me that on Tuesdays, I think the results from the weekends were produced on TV, and the death rates were quite high, and they were saying like, I've stopped watching television because it's so scary to see that results going up and up every sort of week. This was a sort of huge era in our sort of lifetime, and it needed a big sort of community response. And one of the things I think everyone in Tower Hamlets should be sort of proud of was a huge sort of community effort to come out and support each other, and that's what one of the things I wanted to sort of touch on. It was so in Tower Hamlets, there's a big Bangladeshi community, but there's also a huge sort of a ghost sort of community we call, which sort of like a corporate people who don't tend to engage, but they wanted to come out and be part of this community effort. WhatsApp groups were sort of flying around. People were joining from all sorts of employment, from sort of senior level management to sort of youth workers on the ground, and everyone sort of wanted to work together to help those who are vulnerable, and it took that huge community effort to sort of support people who needed support on many different levels, and that was something which was really good to see. The other thing I sort of wanted to touch on, and we work with a lot of young people, and at that time you could imagine the effect on young people, their sort of mental health, which isn't so spoken about enough during those sort of 1.5 to 2 years. And it's especially those sort of the 16 to 19-year-olds who had a huge impact on their sort of education, studying at home, results being given with sort of the teachers' grades and stuff, but they also lost out on as their sort of social life at that age. A lot of them would have been going to college for first time, integrating with sort of different people. They sort of lost out on that period in their life, which they'll never get back. But also younger kids. So kids were being asked to stay at home in many sort of overcrowded homes across the borough. Many with sort of who have extended families in their house, so their granddads, mom and dads, and themselves. So those 3 layers of family cramped into sort of overcrowded homes or big households. But there was also this idea about sort of digital exclusion, which sort of had a great impact on the community, great impact on young people who sort of were asked that their social life be taken online. But we found that many people didn't have didn't have the access to do that. So a lot of people would have had their parents' phones, which were a small smartphone, but they didn't have the appropriate broadband. If there was if they had kids, about 2 or 3 young people in the house, there wasn't enough devices to go around. So there's so much issues across, which sort of came out because of COVID. And I think these are the sort of long-term effects which COVID has actually triggered, we'll see coming out in our communities over the years. But the sort of impact on young people and their mental health has been affected by this sort of and the sort of whole findings of COVID, the sort of whole two years of pandemic and the learnings from it will go on and on. And it's great that we're still speaking about it, but I'm sure on a sort of on a health level, on a public health level, it'll take a long time to understand the real effects to every sort of small communities and our sort of bigger communities. Thank you. I'll stop here.
Very much, Tariq, for your insight. Thanks. Just wanted to say thanks to all our three respondents who have very kindly come in today. I will hand over to John now.
Well, we've got a bit more time. So Jahangir, I think you felt that you'd like to say something a bit more. So the floor is yours.
Oh no, I'll let anyone ask any questions first, and we can take it from there.
Okay.
Should I come in, John? I've got a couple of questions.
Yeah, go ahead, Chris. Yeah.
Or I could ask. I've got questions for everyone, but I'll start. Jahangir, I get to talk to you straight. I mean, you attended the event we had last time. I've been an admirer of what you've been doing, as Ansar said, during the pandemic. You really stepped up.
Yeah.
I was just going to ask you. You mentioned there's something you said about that I'd not heard before. You used the term clinical creativity to talk about the adoption of PPE and so on. I thought that, could you maybe expand a little bit more on that? That's.
No, Chris, that was less about PPE and more about how we managed the initial COVID pandemic when we started seeing patients having severe outcomes from COVID. We didn't really know much about the disease and how it affected patients. We thought it would be similar to common cold, but then a lot of people were ending up in intensive care. So that was less about PPE and more about how we looked after our patients.
You're adapting. Okay. Well, I'll follow up with another question then. I'm not letting you off the hook. I was just wondering, you mentioned that you were often the last person that people saw because you spoke the language, and that's one of the things we saw, wasn't it? People were getting cut off from their social networks through the protocols at hospitals. They didn't have a support network. Did you feel that was something, was it common practice then for health workers to be matched up in terms of language?
Unfortunately, the answer is no. I think quite often there wasn't enough of us. There wasn't enough of us, and resources were so scarce. In intensive care, you usually get one-to-one care between a nurse and a patient. At times it was 1-to-3, 1-to-4, which is crazy in the intensive care world. But, I think personally, I went out of the way to make sure my patients were comfortable. I think a lot of healthcare workers and a lot of healthcare leaders regret the decision of not allowing relatives to visit in those last moments. It's horrible and inhumane to be saying goodbye to your loved ones on an iPad, on a video call, especially for those elderly patients who are not digitally literate. For them, that interaction means nothing, and it was heartbreaking to see that. Yeah, unfortunately, Chris, it wasn't that. There was enough Indian healthcare workers, Pakistani, Bangladeshi healthcare workers, but we were able to pair people up. It's just what resources we had at the time, and just being a doctor in a Bangladeshi community gave me that privilege to see those people and to comfort them in their last moments.
Thanks for that. I think Halima has a hand up, so I'll hand over to her.
Thanks, Chris. so this particular gathering has the advantage of having colleagues from Bangladesh here as well as the rest of Europe. So one question that's bugged me for 2 years, and I will ask it here, is some of the discourses and the conversations you're hearing from Britain about British Bangladeshis and their experience of the pandemic, is there something there that's common, or does that feel like a different conversation? Because presumably those British Bangladeshis that live in Britain obviously have some cultural similarities with people who live in Bangladesh, being Bangladeshis themselves. And if there are similarities, what are they? And if there are differences, is that something about the positionality of British Bangladeshis as minorities in a white majority country that has made that pandemic experience a lot worse? I clearly think it has, but it's just interesting to hear that reflection from Bangladeshi colleagues, because I did get tired and exhausted of hearing cultural explanations of why Bangladeshis were more vulnerable, because they'd also be vulnerable in Bangladesh, wouldn't they? Does that, is a provocation clear?
I certainly feel provoked by that, but I don't think I should be the one answering. Jahangir, Ansir, Tarek, maybe you can come in and help me.
Halima, can you repeat the question for me? I think yeah, if you could repeat the question for me.
Yeah, so what's really bugged me for 2 years is this conversation that feels very much about the specificity and the peculiarities of the British Bangladeshi population that experience all sorts of difficulties. I also wondered whether the Bangladeshis in Bangladesh experience the same specificity, because culturally we have something in common with Bangladeshis in Bangladesh. I guess what I'm getting to is the fact that I think the experience of British Bangladeshis in Britain had something to do with its positionality as a minority in a white majority country, as opposed to cultural factors that may have made our COVID experience worse. Because if that was the case, then our colleagues in Bangladesh would also have a similar story to tell.
Yeah. Well, my parents were actually in Bangladesh during the first wave and during the first lockdown. And it's really interesting how they perceived COVID compared to how we perceived it in the UK. You know, there wasn't that much media attention. They didn't have their daily 5 p.m. briefing with the Prime Minister and senior healthcare leaders. So they didn't feel it was much of a threat. I think in Bangladesh, it was a lot harder to measure the spread of disease, given the resources that they had. And on my recent visit to Bangladesh in July, I found it fascinating how, you know, people wouldn't even say COVID. You know, I would meet people in Bangladesh who had COVID symptoms who would say, oh, it's not that thing. It's not that thing that you're thinking of. And they wouldn't even utter the words COVID or Corona. And so for them, it was very, it almost felt very short-lived, not much of a threat to Bangladesh, and not much of a perceived threat to themselves. So I think it was slightly different to how we perceived it. And maybe, and just maybe, it might have influenced how British Bangladeshis, especially first generation British Bangladeshis, perceived COVID when speaking to relatives back home.
I think Charlotte wants to come in, yeah.
Yes, yeah, may I add a few comments? I think in the context of Bangladesh socio-economic condition of people and geographical locations, these two social dynamics have played a vital role, you know, who get what information in what situations, you know, affected the way people acted and reacted to the issues of COVID-19, where most of the people live under the poverty line, and their life is based on day-to-day earning. In fact, even if they want to bring these discourses to their life, they couldn't. They had to go out to earn their living. think about the rickshaw puller, the maid servants, the government workers. They didn't have the luxury of listening to these discourses around COVID-19. In fact, this insecurity, financial insecurity, made the vast population of Bangladesh go out during COVID-19. And if you go through the research studies, you'll find that those people who worked at the grassroots level, they were mostly they were affected, but at the same time they were quite what would I say, nonchalant about it, because they didn't have any choice. And then again, we did a big research studies on behalf of Bangladesh English Language Teachers Association. And we looked into the, the way students and teachers functioned during COVID-19. Even there, we found that those students who are located in rural background with no access and amenities, they suffered most. And then again, among students and teachers, gender was a very was another marker, which in fact marginalized women in different dynamics. For example, teachers who were staying at home, they had to, because of the breaking of the space, the outer space and inner space, they in fact are doing all sorts of activities within the household. So they were the mother, they were the nurse of the ailing members in the COVID affected members in the family. They were also had to give support to the young children who were attending online classes. They had to take the classes themselves, and on many occasions they had to arrange different gadgets for different members of the family. So it was found that they were affected more by COVID and well-being issues. So it's not that much simple, I guess, in the context of Bangladesh. And then again, if you consider indigenous communities who live in remotest areas in Bangladesh, in fact, they got affected, and there are little research studies done on them to understand the impact of COVID-19. So social dynamics, geographical location, indigenous ethnicity, all these factors played a vital role how they functioned during COVID-19.
I think Ansar wants to say something.
I think I posted that. I was just saying that when we would speak to our relatives in Bangladesh, it was mainly people who were well off.
Yes.
Seemed to be sort of being affected and dying. And you hardly heard about anyone from sort of, poor working class background or of being affected or dying. And there was one theory being floated around that perhaps because they were working all the time, they were much more fitter and able to deal with COVID, whereas rich people had everything done for them by their maids, hence they were too lazy and not fit enough to cope with COVID. I mean, I don't know what truth is in that, but that's what we were told by our relatives.
Here I should mention another thing is the role that government had during that period. The media was, very much restricted to share how many people got infected, and how many people died, because it wasn't a good face for the government to have the real number of people being surfaced. So that is another reason that we didn't know actually, in fact, how many people got infected and how many people died. And these sort of theories, in fact, if you think about these theories, who are coming up with these theories, the privileged class who have all the access to the medicine, all the access to the amenities. You won't find people coming from the lower class background coming up with these theories or their these sort of claims. So there are lots of politics going on. So we shouldn't be accepting this sort of general statement, because yes, as I have mentioned, the government also had a very dubious role during that time, and they had to save their face, and that is why they had to play this sort of role. Another issue is, since again, this is again another statement, that is the government had to play this dubious role because they didn't have the adequate medical service to provide to the vast majority of people in the country. So they did not want to create panic. Since they did not want to create panic, they they had to hide the number of people being infected and died from COVID. So this sort of stand also been taken by the people who work for the government. So yeah, that's what we see in the context of Bangladesh based on research.
Thank you. I think it's fascinating to compare the two experiences in many ways. Was Ansar saying that it was a well-off affected, whereas we're saying in the UK, it was the socioeconomic groups who were poorer that were most affected. There's something interesting there, but for further research, I think, comparative research, John.
Yeah, well, you set me up very nicely there because we've only got 4 minutes left. So I think before I hand over to Chris, I'd like to say thank you very much for everyone. It's impossible to kind of summarize today, but I think it certainly proved its worth in a whole variety of ways. And I think also what was very good was to have such different voices. You know, it's temptation of academics just to talk amongst themselves, and the challenge is how to relate what we learn to policy making, which is an enormous challenge, I must say. But as Jahangir was suggesting, that we should keep on talking, not just have a one-off nice day together. So thank you very much, everyone. And I'll hand over to Chris now. Thank you, Chris.